Hello and welcome to COVID-19, Keeping Up with the Moving Target. I'm your moderator, Faith Rogers. Thank you for joining us. So we are so pleased to welcome our expert faculty members, Dr. Vega and Dr. Ahonkhai. Thank you both of you so much for your time today.
Thank you, Faith. Great to be here.
This educational activity is supported by an independent educational grant from Merck. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Today's learning objectives are to assess the impact of COVID-19 on Black, Latinx, and American Indian and Alaskan Native communities and the factors contributing to health disparities in these communities. We'll also be describing current and potential management strategies for mild to moderate COVID-19 and describe current management strategies and identify potential treatments for COVID-19 requiring hospitalization. As a note, the material presented is current as of November 2nd of 2021. For the most contemporary and up-to-date guidance, if you are watching this on demand, we do advise you to go to the NIH and IDSA guideline websites that we've posted here. Dr. Vega, thank you for your time.
All right, Faith, thanks for the great introduction and for bringing us up to speed with some excellent questions. I'm going to start with a quote because this is really one of the themes we have today. I've worked in a space, Dr. Ahonkhai has worked in a space where we see people of color with the majority of our practices. And so we're used to seeing these health disparities when it comes to things like diabetes or depression or heart failure, and infectious diseases too, like HIV, AIDS. COVID-19 has really drawn out these disparities, though. So, those same disparities we've seen in those comorbid conditions and the social determinants that produce the higher risk in American Indian Alaska Natives, Black communities, Latinx communities, are the same conditions that have made COVID-19 worse for these communities. So I like this quote because this is just an exacerbation of a problem that's longstanding and something we'll call out several times throughout our discussion today. I work in the outpatient setting. I work in the biggest safety net clinic here in Orange County, California. And it's just a nice reminder to me, the fact that a lot of folks with COVID-19 are not hospitalized. Well, we had at our medical center, we had, a overflow capacity with two huge tents with COVID wards, out in the lawn in front of our hospital. Most patients, 80% or so, are managed as outpatients. That's the section I'm going to take as we go through this. This slide, for those of you who need a little bit of a refresher, maybe haven't seen as much COVID, this is a really nice graphic because it describes the virology of COVID-19 as well as the symptomatology, and it even has some guidance as to when you want to initiate treatment. So the red lines are SARS-CoV-2 levels, and then there's a corresponding tab below that describes symptoms. Remember that patients oftentimes, as they get more of that severe inflammatory response, day 5, even day 7, day 9 of illness, they can do worse. So we have to monitor our patients with COVID-19 routinely, and I really want to shoot for about every 2 days until they are feeling significantly better to avoid folks deteriorating without our knowledge and then ending up in a severe crisis, going in the emergency department and eventually the ICU. And then look at treatment as well. You really want to start antiviral therapy. You want to start monoclonal antibodies as soon as possible. Think of them as antiviral agents. Generally, antiviral agents work the sooner you can get them initiated. With immunomodulators, they do have some role earlier if the patient has severe illness, but a lot of times they're used later in the illness after day 5, after day 6, when patients have that severe immune response and they're in the hospital. And so Dr. Ahonkhai is going to be addressing that issue shortly. In terms of who is at high risk, it's most of the patients I see every day for certain. When you throw in diabetes, obesity, a history of chronic kidney disease or COPD in the mix, and those are all very relevant conditions. It's the patients that I see every day in my practice. And so I'm really aware of what our protocols are for early treatment, particularly monoclonal antibody treatment, for high-risk individuals because I want to be able to get that treatment on board. My goal is usually within 24 hours of diagnosis of a positive infection for SARS-CoV-2, I want that high-risk individual getting a monoclonal antibody therapy because the sooner that those agents are on board, the more effective they're going to be. And this list does change a little bit, but and I would just also point out the risk factors are generally additive. So when you have I don't have patients with one of these risk factors. I have patients with 4 or 5, and unfortunately, that person's at just much higher risk for complications of COVID-19. And we know that that overall communities of color have been disproportionately affected in terms of the incidence of COVID-19, as well as the complications, particularly the complications of COVID-19, including hospitalization or death. So just to call those out specifically, American Indians, Alaska Natives, Black and Hispanic Latinx communities, higher risk for hospitalization and mortality. And they're getting more cases because these are frontline workers. There's folks who really need to work to live. They live in more crowded conditions, so it's been very difficult having a 1-bedroom apartment shared by 2 families, total of 9 people, and 1 case of COVID-19. How do you isolate in that situation in any meaningful way? It's been really difficult and trying. And so luckily, right now we're in a spell here in Orange County where our numbers are down substantially. And I really hope that we don't see another significant surge anytime soon or ever, because we still haven't solved that situation, obviously. When it comes to, I think we've gotten better, certainly with vaccination, with masking, but those social determinants, they're still there. They're just as prominent as ever, as that first quote alluded to. And so this is data from the COVID net nationally, looking at over 140,000 hospitalizations. So you can see those same trends, that for the risk of hospitalization, ICU admission, and death, higher for those, particularly for those 3 populations I mentioned earlier: American Indian, Alaska Native, Latinx, Black. And then just to simplify in terms of mortality rate, this pandemic is killing a lot more people of color, proportionally versus whites. And where are most of those deaths occurring? So we know that there's a disproportionate effect in COVID-19 of killing people of color versus Asian Americans and white Americans. But where the greatest disparity is in terms of that risk of death is actually among younger people. So folks in their 80s, of course, are at a higher risk of mortality overall related to COVID-19. And there's less of a racial difference based on race and ethnicity. But get down to people between 40 and 50 years old, or 30 and 40 years old, there we're seeing a lot more folks of color die due to COVID-19 proportionally. And that's why we see a lot of kids who are affected and now are losing a caregiver due to COVID-19, which is a real tragedy. Okay, so let's think about how do we go about managing folks with COVID-19? How can we prevent some of these very difficult and tragic outcomes? One is good diagnosis, and I mentioned monitoring symptoms. So we use telehealth. Pulse oximeters are much more available, and wearables do work, but they don't always work exactly right. I have gotten calls, panicking calls saying my oxygen saturation is 60%. What do I do? Well, how do you feel? I feel great. So you have to teach patients how to use these appropriately, and some of the same tricks we've used, especially just rechecking it, turning it on and off. The simple stuff needs to be reiterated because patients and their families don't necessarily have that training. I'm a big believer in supportive care, but I'm also going to be aggressive because most of my patients do fall in the high risk category. So I'm going to try to get some kind of antiviral treatment on board as soon as possible. And I think you're probably familiar with your, with the national recommendations regarding isolation, at least 10 days. But patients, of course, can break isolation before all their symptoms are resolved. If it's just a lingering cough, but otherwise they feel fine, they've been in febrile for more than 24 hours, then they can, and it's been 10 days since the onset of symptoms, of course, they can be released. And quarantining, I don't think those rules have changed for some time. We're probably pretty familiar with those at this point as well. So let's talk about getting more active, because we know that monoclonal antibodies work well, but they've also been underused nationally, and I'd be happy to speak to why I think that is. But one of the first on the scene was bamlanivimab. Then it was paired with another antibody that binds to a different epitope of that SARS-CoV-2 spike protein called etesevimab. And now that cocktail, you're like, wait a minute, I didn't think, maybe you're thinking, what happened? Bamlanivimab and etesevimab went away. Well, they did. Now they're back. So against the beta variant, they weren't as effective, and so they were held from the market. But versus Delta, which is, of course, the predominant variant we see right now in the United States, there's mild to maybe moderate resistance. It kind of depends on the study you're looking at, but not severe resistance against Delta. So bamlanivimab plus etesevimab was reintroduced in the market since early September. So we've had it back for a couple months now in total. Castlevania plus imdevimab, this is one that has not demonstrated strong patterns of resistance to any of the mutants of COVID-19. And I think I'll call out a couple things in these studies we go through. Just look at how diverse the pool of patients is in these studies versus a lot of randomized trials. I think that's great, and I think it was necessary just because of that's who's getting infected with COVID-19. So you see higher proportions of Black and Latinx patients in these trials versus usual. I'll also call out that castlevania plus imdevimab, not only the calling cards for these agents are, just go back one, the main outcomes is they're effective in reducing those severe consequences, hospitalization or death, with bamlanivimab, etesevimab, an 87% reduction in the BLAZE-1 trial. With castlevania imdevimab, 71% reduction with that approved 1,200 milligram lower dose. But in the case of castlevania plus imdevimab, there's also reduction in terms of duration of symptoms. That's important for patients getting back to work early, back to school early, just feeling better. Of course, we want to make them feel better. And also, this one has a special EUA that it can be applied subcutaneously in situations in which an IV is not available. And I think that's been one of the main difficulties with the application of monoclonal antibodies overall, is some of the requirements about having an IV infusion, monitoring patients for an hour during the infusion and an hour afterwards, and having crash cart available with people who know how to use it. That's a lot of resources, particularly for under-resourced communities. And so I think it's some of the logistics that have held back the use of these agents, because it's hard to argue in terms of the efficacy when you're thinking about risks of hospitalization and death. So sotrovimab was the latest to come on the market. Its EUA was in May 2021. And it was granted based on this study, which showed an 85% reduction in hospitalization or death versus placebo. This was stopped early because there was a clear efficacy benefit with sotrovimab. So we have different options in terms of monoclonal antibodies. And I think that, for me in my primary care practice, what I'm really doing is just keeping up with, okay, what's going on? What are our protocols? How do I get these agents on board? And to me, any monoclonal antibody is going to be better than waiting, a couple of days for a certain monoclonal antibody that's being shipped or something like that, or sending patient to a different center where they may not be able to get it. Any of these agents is going to be better than nothing. And so therefore, I'm really trying to get them on board more quickly. And this is a study that verifies that the monoclonal antibodies do work in a large urban medical center. This is data from February. And you can see that the risk of ED visits or hospitalization, in this case not death, but ED visits or hospitalization, was overall reduced 82% in those treated with the monoclonal antibodies. So therefore, these agents really do work both in the clinical trials, and then also it's nice to have real-world data on top of that. So who should get them? It's very important to know these rules as well. So it's really reserved for folks who are at high risk of complications of COVID-19, but that's a pretty long list, and that includes Black, Latinx, and American Indian Alaska Native patients. So don't forget about those critical groups. They have to be at least 12 years of age. They have to have symptom onset within the past 10 days. In the clinical trials, patients were being enrolled on day 6 or 7 of illness. So I could assume that if we can get the treatment on board in 2 or 3 days, we might be seeing even better outcomes in prevention of hospitalization, for example. But there are those rules about it's an hour-long IV infusion. Even with castlevania plus imdevimab, if it can be given IV, it's preferred to be given IV instead of sub-Q. And even if it's given in a case where you don't have that option, it's given subcutaneously, patients still need to be monitored for an hour afterwards by trained personnel. So this is why protocols are important. In terms of the criteria for monoclonal antibodies defining those high-risk conditions, it's a similar list to what you saw previously, and I'll just point out because I'm not going to read this long list to you, but do understand that you do have some discretion. If you have a patient with a borderline BMI and they're 62 years of age, maybe because they're close on a couple risk factors, and you're in your clinical shared decision making with the patient, you decide that a monoclonal antibody will be helpful for them. Go ahead and you could recommend it. All right. And so this is current guidelines from the National Institutes of Health, as well as the Infectious Disease Society of America, that really all of the monoclonal antibodies can be applied, but we do also, while we have to think about what are our protocols and how do we get these agents on board expediently for patients, we also have to be aware that variants are emerging, and right now there's no strong recommendations regarding particular variants that I'm aware of, because you can use any of these agents, but in 2 or 3 months, who knows, it's COVID-19. So we have to keep up with the epidemiology of SARS-CoV-2 as well. More to do, but that's why we're here to help. One thing that's really exciting is that, I do have a lot of families that live really close together, and you have 3 generations, and maybe the 24-year-old person who does deliveries becomes infected, and they have contact with an 84-year-old grandparent who has heart failure and COPD and severe diabetes and end-stage renal disease. So I've actually seen cases like this, and I have not used the prophylaxis yet, but there is evidence that prophylaxis can work with Castlevania plus Imdevimab in this study looking at household contacts. And so just like we might use a drug like oseltamivir for the prophylaxis against influenza in a high-risk patient, you can use Castlevania plus Imdevimab as post-exposure prophylaxis with a substantial reduction in any type of infection, but particularly symptomatic infection. And so who is this indicated for? It's indicated for folks who are at high risk, who are unvaccinated or expect to have an inadequate response to the vaccine. That means they're somehow immunocompromised. And they have to be at least 12 years of age. So those folks, especially in those very high-risk conditions, I would really try to get Castlevania plus Imdevimab on board for that at-risk individual, because it can prevent infection and potentially severe outcomes such as hospitalization and even mortality beyond that. Bamlanivimab plus etesevimab also has proven to be effective as post-exposure prophylaxis for, and in this study, it was actually in a skilled nursing facility. So this is a specialized setting, but we know that COVID-19 has had its, I think, most severe impact globally in, in those clinical care settings where you have like a skilled nursing facility. And so you can see that patients were randomized to, this is just bamlanivimab alone and a placebo, and there was an 80% reduction overall in terms of the rate of symptomatic COVID-19 among residents, and then a 57% reduction among staff. And so bamlanivimab plus etesevimab also has an indication, similar to the other one, high-risk patients, unvaccinated, or they're going to have a poor response to the vaccine, at least 12 years of age. They have an indication as well for prophylaxis. All right. And I think I just, my information services department is flashing me some kind of warning, which I'm going to ignore, but I'm not going to ignore what you probably really want to talk about. And that's molnupiravir. So molnupiravir is, so this agent is not approved yet, but it's getting a lot of attention because it is an oral agent that appears to be active against SARS-CoV-2. We don't have published data on it, but we do know from press releases that in a randomized trial with 775 outpatients who were unvaccinated and had at least one risk factor for severe illness, this 5-day course of molnupiravir was associated with approximately about a 50% reduction in the risk of hospitalization or death versus placebo. And it was effective across the different variants that were in circulation at the time. So molnupiravir is currently under review by the FDA, and so that's exciting. It could be exciting to have another option. A lot of those logistical issues could be potentially drawn down, but there's also still, certainly things we don't know, and we have to look forward to more data and a publication of this trial data as well. I'm just going to make sure I didn't skip another one as my nope. Oh yes, I did skip one. Sorry. So boy, when they hang banners all the time here at UCI, and it's like we know the emergency department's down for saturation. It's been that way for several months, but it does like make your computer reset. So I apologize for that and skipping this, because this is another area that's important, and I'm going to call on Imana, to get her perspective on this. She's looking at hospitalized patients. Now, just remember that that monoclonal antibodies currently indicated generally for outpatients is where they're primarily used. There was a trial early looking at monoclonal antibodies among inpatients, and it didn't produce positive results, so therefore it didn't receive that recommendation initially. But among folks who come into the hospital with COVID-19 and they're not producing an antibody response, there might be some benefit for these monoclonal antibodies in terms of, a very important benefit, because we're talking about a potential mortality benefit. Not if they're mounting that immune response, but among seronegative patients for SARS-CoV-2. And Ima, can I bring you in for a second and get your take on using these monoclonal antibodies among certain inpatients?
Yeah, I mean, I think, this trial is providing some intriguing data, but of course we know there are, in our clinical experience, actually, at Vanderbilt, in my institution, we actually are using some monoclonal antibodies for inpatients who are hospitalized for reasons other than their COVID-19 infection. So I think that's a population where where we can comfortably use it. But this provides some intriguing data that there may be a role. Of course, we're going to get to the inpatient side in a minute. And like you said, this is about early treatment before kind of the cat is out of the barn, so to speak. And so if they're hospitalized, you may have kind of missed that window of opportunity. But this provides some nuance for, seronegative patients where there may be an opportunity to alter the disease course early. But I think we need more information on this.
Yeah, so right now, the only time we really should be thinking about using monoclonal antibodies among inpatients is folks who are admitted for another reason, say exacerbation of renal disease, or they're in an accident of some type and they're found to be SARS-CoV-2 positive and they're high risk for complications. So you're giving it to those folks, I'm sure, especially if they're not vaccinated, correct?
Right, but yeah, exactly. Although it shouldn't matter, but with supply chain, it does.
Yeah. So we've had the same issues here, and now we're back up to speed and running, and that's generally what happens. But now we have our surge is going down. So yeah, it's been a challenge to keep up with it and staying ahead, because it's quite an unpredictable beast, SARS-CoV-2. So that said, despite all our best efforts and our best agents out there, some of our patients are going to be hospitalized. That's inevitable. And luckily, we have great physicians like Dr. Ahonkhai to take care of them. She's going to talk about hospitalized patients with COVID-19.
Great, thank you. So yeah, as an infectious diseases physician, this is where a lot of my time has been spent over the last year and a half or so. This is a great slide just giving an overview of the NIH recommendations for inpatient management of people with COVID-19 infection. And so, and really emphasized here on the left is kind of the spectrum of disease severity. So for patients who are hospitalized with the mildest disease and they do not require supplemental oxygen, there isn't really data to support either the use of steroids, dexamethasone, or remdesivir. So that's really supportive management for that group. As they move on in disease severity and require supplemental oxygen, then we have data which will show you to support the use of remdesivir, dexamethasone, or a combination of the two. So in our institution, we tend to use both, but we'll look at the data there. For people who are have worsening disease on supplemental oxygen, then we can add to that armamentarium. And so this is requiring high flow oxygen or non-invasive ventilation. This is an important benchmark. For those patients, we can add on baricitinib or tocilizumab to the dexamethasone or remdesivir, whatever regimen they're on prior to that. When we cross the threshold to people who require mechanical ventilation or ECMO, this is where we can use dexamethasone or add tocilizumab if it's within 24 hours of the ICU admission. So time is still of the essence in this protocol in a slightly different way, but these are the important kind of inflection points. Is the patient hospitalized? Yes. Does the patient require oxygen? Is the patient rapidly progressing on the initial therapies, and is the patient requiring mechanical ventilation? So we'll go over the data there. So this slide shows data from the ACT-1 study, and this is looking at the treatment outcomes for remdesivir versus placebo. So remdesivir is the blue line, the placebo or control group is the red line. You can see on the figure A on the top left, in the overall group, the proportion recovered looks to be higher in that remdesivir arm, versus the placebo arm. And then if we see in the important subgroups that this study broke out, we have in the top left B is, top left on the right panel, B, is patients not requiring oxygen. And then on the top right, C, is patients requiring oxygen. You can see there's a difference there in the separation of that blue and red line. And that's really where we can see that patients benefit from remdesivir when they're receiving oxygen. Those lines are overlapping in patients not receiving oxygen. And certainly there's overlap for patients who are on mechanical ventilation or on high flow oxygen. So this highlights again where we see the benefit from remdesivir, patients who are hospitalized and requiring oxygen. So a picture sometimes is worth 1,000 words there. So this next slide is highlighting data from a landmark trial published in 2020 by the Recovery Group. And the premise for this study was that it was increasingly being understood that there was a subgroup of patients with COVID who had a severe inflammatory organ injury associated with their disease. And we saw really elevated levels of inflammatory markers like CRP, ferritin, IL-1, IL-6, different acute phase reactions. So you can see from this study, a UK trial, 2-to-1 ratio of over 4,000 in the control, 2,000 in the dexamethasone arm. It was actually halted early because of the benefits shown, which we can see here on the right. So people in the usual care arm, this was 28-day mortality as the outcome. Usual care had a higher mortality than with the dexamethasone group. And you can see, so this was the first drug that was showing mortality benefit. But if you look all the way on the right, individuals who were not on oxygen, people who didn't require oxygen, seemed to actually do worse. So the benefit here for dexamethasone were in people with much more severe disease. So if they were on oxygen and requiring mechanical ventilation. So that's the important inflection point there. So this is another study coming from the recovery arm looking at, for the recovery trial, looking at tocilizumab. So tocilizumab is a monoclonal antibody that targets the IL-6 receptor. So IL-6 is one of those cytokines that's released in response to infection and stimulates a really robust inflammatory pathway as part of the acute phase response. So tocilizumab was studied against usual care. In this trial, importantly, most of the patients were on steroids. And about 41% of them were on non-invasive ventilation. So you can see here from the figure on the right, looking at 20-day outcomes, that patients in the tocilizumab arm in purple had reduced 28-day mortality compared to the usual care arm. So this is data highlighting the role of tocilizumab in those patients who were on steroids and requiring non-invasive ventilation, or some of them requiring non-invasive ventilation. So representing that category of patients who were, doing worse on initial therapy with oxygen, requiring oxygen on initial therapy with steroids. And this forest plot really shows, again, the benefit of tocilizumab over usual care for most subgroups. So here, the box that's highlighted is looking at days since symptom onset. Dr. Vega did highlight this for outpatient therapy about the importance of time to treatment, and that's really being highlighted here as well. So patients who started therapy less than or equal to 7 days from symptom onset, you can see they did a little bit better with the line there not crossing 1. And then also you can see subtypes looking at the type of respiratory support required. So if they were had no ventilator or a non-invasive ventilation, they had benefit from tocilizumab. So those are the important points highlighted from that forest plot. So moving on to baricitinib. Baricitinib is an orally administered medication. It's a selective JAK1/2 inhibitor, and this is also something that really impacts that inflammatory cytokine pathway that we see in a subset of patients with severe COVID-19 disease. So again, we're looking at the ACT-2 trial, and we can see that baricitinib was associated with an improved time to recovery when it was given with remdesivir in patients who required supplemental oxygen, but not on mechanical ventilation. Importantly, that trial didn't look at baricitinib with corticosteroids. So, of course, we looked at that progression of therapy from, remdesivir and steroids. This trial looked at baricitinib without corticosteroids. Then we had the COVID barrier trial, which kind of addressed that gap, looking at the standard of care where 19% of patients were on remdesivir and nearly 80% were on corticosteroids. When we look at these data, we see baricitinib in the purple showing a 38% reduced risk of mortality. So that's the important role of baricitinib. Again, we need to just be thinking about, is the patient hospitalized? Does the patient require oxygen? And whether or not they are progressing on initial therapy with remdesivir and dexamethasone to require escalated therapy with baricitinib or tocilizumab. So that's kind of a snapshot of inpatient management. But I think we did want to spend a good amount of time talking about disparities in treatment outcomes. Well, really all along the cascade, from infection to hospitalization and treatment outcomes with COVID-19. And Dr. Vega provided a nice introduction to that at the beginning of the presentation. And we see that these disparities have persisted throughout the pandemic, unfortunately, driven by some of the social determinants Dr. Vega mentioned driving these issues. This is, get the right slide, yeah. So this slide is highlighting from Milwaukee Academic Center. It was conducted early in the pandemic in March of 2020. And in Milwaukee, African Americans represent about 27% of the population. That's higher than the US as a whole. But what's important here is that they saw that Black individuals, a greater proportion had greater than or equal to 3 comorbidities, that would be important for COVID outcomes. Poverty status was higher in the Black than the non-Black population. And COVID positivity was associated with Black race, male sex, and older age. So, and then when they looked at hospitalization, that was higher among both Black individuals and people living in poverty. Differently, when they looked at ICU admissions, that was associated with poverty, but not with Black race. So that was kind of an interesting disparity there. But I think it really does highlight that it's a combination of, it's not just Blackness or race by itself, but really a conflation of risk factors that may describe comorbidities that are driving worse outcomes, and poverty status, and the living conditions that create those problems to begin with. So ultimately, they stood here that neither race nor poverty status was associated with death or with mechanical ventilation, but was really important for the earlier kind of steps in the outcomes by race. So I think I will stop there and pass it back to Dr. Vega for the next slide.
Yeah, thank you. Great summary. So yeah, just to be clear, this is not genetic factors about someone who's got some specific immune deficit in Latinx populations, or that folks with who are Black happen to be more susceptible to SARS-CoV-2 infection. It really is about those social determinants of health. It's about those pre-existing conditions that have led to worse outcomes in Black and Latinx communities. But I think the heartening thing in the Milwaukee study was that we saw that when you accounted for, say, poverty, and then there was Black patients had equal outcomes in terms of risk of mechanical ventilation or mortality associated with COVID-19, even though they were hospitalized. But we know that for other conditions, and gosh, there's a lot of them. We're talking about revascularization for coronary artery disease, pain management, in fractures, and there's a list of others, both in kind of in vitro simulated cases, but also real world data support that there are disparities in the way we as healthcare providers take care of patients. And we didn't see that necessarily during the pandemic. There was several studies which supported the fact that that Black and white patients were receiving similar levels of care with similar outcomes when all those social determinants could be adjusted for. But this study published in June 2021 contradicted that. And it was a large sample of individuals from across the country. So it really was a more national sample of over 44,000 Medicare beneficiaries. And what they found overall was that in unadjusted analyses, as expected, because other studies had showed this as well, Black individuals were at a higher risk for either inpatient mortality or discharge to hospice within 30 days after hospitalization. But when they adjusted for those other factors, including poverty, living in an area without access to healthcare resources, that difference persisted. So that difference persisted. So this was a clear sign of unequal treatment. And it really was due to certain hospitals which weren't following, the right protocols, which weren't using the interventions that we know could help patients. And when those hospitals were accounted for, and if they had been performing as the better performing hospitals had been, well, then that risk of mortality, the difference between Black and white mortality, increased substantially in this study. So this is a sign that there is, some evidence of unequal treatment, and something we have to be very aware of as we are healthcare providers. And I'm going to hand it back to Ima, and she's going to talk about, some of these differing and adherence to standards of care in the inpatient setting.
Yeah, thanks. And, some of you may have heard of Dr. Susan Moore, who kind of live streamed some of her treatment with COVID-19 and eventually succumbed to it. And I think her story and what she wanted to share with people really reflected, what Dr. Vega highlighted on the last slide, which is kind of differential a treatment associated with different outcomes. But on this slide, we're really identifying more now where varying standards of care may exist. So this was a retrospective study looking at the use of different inpatient treatments from Desivir and dexamethasone, and looking how these varied across health centers and how they varied by race. And so you can see in the figure on the right that both remdesivir and dexamethasone had lower utilization in Black and Hispanic patients. Dexamethasone appeared to be underused among people who required mechanical ventilation. Of course, there's a variation in patient mix and in drug access and treatment protocols, but this really does highlight that there are differences in standards of care that are implemented by race, and that we have a lot of work to do from an institutional perspective to address those disparities. So going back a little bit again to the determinants of health, this is a nice figure highlighting that there are a number of factors that contribute to health and health outcomes. Some of them are linked to individuals' behavioral patterns, and we like to think about that a lot when we think about individual predictors. But there are, genetic predispositions, there are social circumstances, there are healthcare factors, some of which we just talked about, and environmental exposures. And I think, we can look at it this way, and we can see that there are things that an individual patient may or may not have any control over, but that may be really important in determining their health outcomes. If we look at it another way, we talk about social determinants of health. We've mentioned them a few times on this presentation, and they can be looked at this way. There are a number of factors that determine, the environments in which we live and work and do our daily deeds. Economic stability, physical environment, education, access to food, community and social context, and the healthcare system. These work together to determine health outcomes. Like Dr. Vega said, the disparities that we see in a number of chronic health conditions are really the conflation of all of these. We may see, for example, that people with COVID-19 who do worse have more comorbidities. But those more comorbidities may be driven by the fact the fact that an individual lives in a particular neighborhood that has no green space, that has food deserts and they don't have access to healthy food, that doesn't have a good infrastructure for providing health care. And so when you layer on these challenges, then you may end up seeing individuals in certain communities, like racial and ethnic minorities, who have a greater burden of a number of chronic diseases that lead to a perfect storm, as we've seen with COVID-19. So I will, I think, pass it back on to Dr. Vega to now talk a little bit about vaccines.
Right. So it's important to share results based on race and ethnicity regarding vaccination rates in the United States, because you can see a clear difference. And remember, vaccination is really our #1 public health strategy for dealing with COVID-19. And unfortunately, we saw, especially if you look back between March and May 2021, you could see a distinct difference in terms of rates of vaccination as those among Asian populations, white populations really took off, much more lagging in terms of Hispanic and Black populations. And yet we're still not getting there. Then the curves bend, and as we all know, there's been a ton of controversy about vaccinations and mandates and how, what's the best strategy in terms of policy to get more vaccines on board. But it really does come down to the fact that we still have, even though individuals who are Black and Latinx have much higher risk of infection and complications, we're still seeing lower rates of vaccination, even as we've been able to roll more vaccines out into the community, which was a severe problem at first. And there's a myriad reasons for that. And so it's not just one factor, but this data shows that there's many difficulties, from logistics and infrastructure to worries about costs to worries about side effects that are more prevalent among Black and Hispanic people versus white people. And I'm happy to talk, because I want to save time for the Q&A, about vaccine hesitancy and how we work with it. But in focus groups, which really seems to be most effective is acknowledging that there have been historical mistreatment of Black and Latinx persons, and so that's real, and that you want to be able to recognize that, and again empathize with your patients who have that as a concern, and develop trusted messengers. And I like to think that I'm a trusted messenger, but I feel like sometimes that's been tested. I will say more so during this pandemic than any other time. I've really felt like I haven't been able to have the influence and I think the closeness of a relationship with patients whom I've known for years. This is not like for my first time seeing them. I've been taking care of their diabetes and their shoulder pain, et cetera, for a long, long time. And yet there's a little bit more distance now that I feel when talking about vaccination specifically, and that is new. And so what I've tried to work, how do I work with it? I definitely hear them out. I hear their point of view. I personalize and talk about how I and my whole family has been vaccinated. And I really emphasize there's some of the other potential benefits of vaccination, not just in terms of prevention of COVID-19, but thinking about complications, including long COVID, thinking about protecting one's family and the people they care about, particularly in those crowded living conditions. And also just finally the peace of mind that comes with having vaccine versus no vaccine. And so and the structural barriers are also very, very important to address as well. And that's a continuing work in progress that we need to continue to invest in over time. So I'm going to summarize right now before we get to a patient story. So overall, we know that Black, American Indian, Alaska Native, and Latinx folks are at a higher risk for both COVID-19 infection, but also hospitalization and death. Monoclonal antibodies are effective, particularly for those patients at high risk. They have to be at least 12 years of age. Molnupiravir, we'll see. It's got an exciting trial that showed a overall 50% reduction in the risk of hospitalization or death versus placebo, but not yet approved. But it could take away some of those logistical barriers that we've both alluded to during this presentation. And for hospitalized patients, your best bets are remdesivir, along with drugs like dexamethasone, those are the ones that are indicated for more inpatients, not outpatients. But Dr. Ahonkhai did a great job of summarizing that data. What we haven't heard so much from this discussion is the patient perspective, but we do have a short video clip which just shows, now this is very early in the pandemic, but I think it's still very telling as to the distress and the severe nature of this pandemic and this particular infection, and just how patients can be treated and unjustly treated at that. Please roll it.
I really was feeling bad and I knew something was wrong. So when I did wake up that Friday morning, I drove myself to the ER. The doctor came and she said, "We can send you home on some oral antibiotics." I said, "If I stay here, will I get the antibiotics IV?" And she said, "Yes." And I said, "I think I want to stay." But I did that because I was scared. The nurse that was taking care of me that day, I requested to her that she contact the doctor because I had been on every antibiotic and my temperature was still 104. And he said, "We're going to test you for a respiratory panel, we're going to test you for HIV, and we're going to test you for the coronavirus." I just hear someone screaming in the hallway. And I told my girlfriend, I said, "That's my mom." So my girlfriend gets up to see, was that really my mom? And when she got up and went out the door, a security guard came and slammed the door closed. And I'm banging on the window, trying to know what's going on. The security guard kept his back to the door the whole time. I turned the wheelchair around and I looked up at the television.
We are told, in fact, that there is a person who is being treated in New Orleans that is from Jefferson Parish right now.
This is a person who has contracted the coronavirus. They are from Jefferson Parish, but again, they are at the VA hospital in New Orleans getting treatment right now.
Who do you think that was?
Great. Thank you so much for letting us hear Kim's story. And Dr. Vega and Ahonkhai, thank you so much for all that very important information today. As a reminder, we're going to move now into the Q&A. Our first question is there any data by race or income regarding time to testing, diagnosis, or location of care and outcomes?
And yeah, in terms of data, I don't think there's a lot of data saying that time to testing is necessarily that different based on race and ethnicity. But there is data as to where the testing is occurring. The use of patients with COVID-19 among Black and Latinx populations in the ED is much higher, which is why we're constantly down for saturation here in Orange County. Because a lot of patients, that is their primary care. It kills me as a primary care physician to see that. I want just tumbleweeds floating through the ED every day. That's my goal as wellness. But yeah, instead we have the reverse situation. So in terms of where those tests are being done, it's more in the ED. And folks who are diagnosed, if you're Black, if you're Latinx, you're more likely to be diagnosed at a more severe stage and then be subsequently admitted with COVID-19.
Okay. And our next question. How can I talk to my patients who are very skeptical about the vaccine?
Ima, you want to take that one? I already gave some of my perspective on it.
Yeah, sure. I think, obviously, as you could see me, I'm an African-American female. And I think a lot of times, people ask me to come and talk to a group of individuals who may be hesitant about vaccination. And I never see my job as a provider as convincing someone of what to do. I try to meet people where they are and make sure I hear respectfully what their concerns or their fears are. Because there's so much misinformation and disinformation, I try very hard to address that. And then I try to see kind of what their motivations might be for getting vaccinated and making sure people understand the different layers of protection for themselves, for their family members, for their community. If their goal is just to get back to normal life, that's a reason to get vaccinated. If their goal is to protect their grandmother, that's another reason. So I try to find, where there may be goals and priorities in that individual's life that could align with, what we know from a public health perspective and epidemiological perspective would benefit for them.
Yeah, I'll just echo that, Ima. This is such a great point, is to meet the patients where they are. And I will say that right now we are at a unique time where we can do that, getting back to normal life, wanting to see family again. Guess what's coming up? A bunch of holidays where it's all about family and gathering and, sharing with each other. And boy, it'd be nice to share and keep everybody protected. So I've gotten a few vaccinations on board over the past couple weeks that heretofore were very resistant against vaccines, because it's about protecting the people they care about. So really try to play on that now, because if you're going to think about protecting for Thanksgiving, today being November 2nd, you really want to start the vaccination process, right now.
Great, thank you so much. And our next question here is, as oral therapies emerge, where do you think antibodies will fit into treatment?
That's a great question, and I don't have a crystal ball on these things, but I still think the monoclonal antibodies have now such a strong record of achievement across multiple different types of trials as well as real-world data. So I think that they'll fit in. It's just another piece of, we've got different tools that we can use to prevent the severity of COVID-19 infection. So of course, the best is prevent infection in the first place. But monoclonal antibodies, I think, will still have a strong role to play moving forward, no matter what happens with molnupiravir.
Great. In our next question, when do we expect more information on molnupiravir and the EUA?
Ima, do you have a crystal ball on your desk? I don't have one here.
I don't have a crystal ball there. We're all anxiously awaiting to hear more information on that along with you. So I'm not really clear on what the timeline is, but we all hope that will be soon, because I think that will, obviously logistically be a lot easier to administer oral medications on an outpatient basis than infusions. So we're all anxiously awaiting that.
Okay, fantastic. Well, thank you again to both of you. And for our audience, if you'd like to claim credit, please do click that claim credit button. Be on the lookout for our 30-day survey. You will get that through email. And as always, your responses will help us develop further education. So we thank you for joining us, and have a great day. Dr. Vega and Dr. Ahonkhai, thank you so much.
Thank you. Stay well, everyone.